Well, I hope everybody had a great weekend, nice holiday, and that the exam you just took went well for you all. I guess that was your last exam for 10:30, and tomorrow you have exam 7 for 10:40. And my goal is to be able to do a review with you guys during class time today. So this is how it's going to work. I'm going to finish up with contraceptives, and then our last presentation, which is on the history of contraception. They Aubrey and Mark will be doing their presentation, and then as soon as they're done, we will continue on with and finish up with Unit 18. And then we'll give you a little break, and then Carolyn will get on with you and do Unit 16, which is the human sexuality unit. And then as soon as she's done, she'll give you a little break, and then I'll get back on with you and do a review. All right. Yes, good morning. I already... let's see, I'm ready to go with this and finish up with Unit 18. So this is where we left off in the middle of talking about hormonal contraception, and I just finished up with hormonal contraception. And so now we are ready to move on to, these are the, this is a long-acting, the long-acting contraception, reversible contraception, and this is an intrauterine device, and it has one of the best success rates. It used to be considered a little bit risky in that we used to think that it increased the risk of PID and the problems associated with PID, like infertility and ectopic pregnancy. However, it was discovered that the only increased incidence of PID is if it was placed while there was a chlamydial or gonorrheal infection or some sort of infection. So, so those things can happen too. I'm not sure what the, like what Kimberly just put in the box, I'm not sure what the incidence rate is. It is considered to be safe enough that the American Academy of Pediatrics has actually recommended that it be the first line contraceptive method for adolescents, since it can be more long-term. It is a small T-shaped device that looks just as pictured and fits in the uterus, just like it shows. It's inserted by a healthcare provider, and it has a string attached that comes out through the cervix, and it can be expelled. And so women who use these are taught to check for the string periodically, like they recommend approximately once a month, just to make sure that they can still fill the string there. And if they don't fill it, they need to contact their provider and just for an evaluation to see what's going on. The contraindications are infections, like I just was talking about, because those can increase the risk of PID. But and if a woman has PID, or don't place it, if she develops PID while it is in place, while an IUD is in, she should be put on antibiotics and treated for the PID, obviously, like anybody would. And then the provider and the woman will have discussion as to whether or not to remove the IUD. There's two types. One is the copper, that's the Paragard, and copper is the copper ions are spermicidal, so that's how it works. Kimberly, it depends on some women, the hymen is not a factor. Others, it is more of a factor. So they would deal with it as needed. And they do have a smaller size that they use for adolescents. So this is what's on the slide is pretty simplified. It makes it look like there's just the two, but there are actually quite a number of variety of sizes and strengths and how long they last and that. But the Paragard, generally the copper one, lasts about 10 years. It does cause heavy menstrual bleeding and cramping, whereas the Mirena, which it works by having progestin embedded in it, so it is combined with hormonal contraception, that lasts about half as long, so 5 years, and it causes amenorrhea. So it causes kind of the opposite problem as far as menstruation goes as the copper one does. So when women are switching from one to the other, they need to be cautioned to expect a different sort of menstrual flow. Just a second, I got something extra.
I'm sorry, I know you're teaching. I forgot my keys. I was wondering if I could jump in for 1 second. Hi, friends.
Jody?
How are you? Kim, you're always so excited to see me, and I love it. Okay, 2 announcements. One, the Disaster Virtual Clinicals tomorrow. I've set out an announcement about it. You're all going to join a Zoom, and we're going to do it virtually. But it's required clinical time. It counts as mandatory clinical hours. So make sure you've logged on. We're going to roll a couple of times throughout to make sure everybody's on and getting the hours that they need, okay? There's a whole module about it. There's some handouts that she usually does in there also, all right? The next thing I wanted to say is I sent out an announcement about a clinical preference for next semester. So that is in the calendar lab schedule module in 1031. These are both in 1031. The clinical preference sheet just says, like, I work at Ogden Regional or I work at McKay, what unit you work on, if you have a primary children's unit preference, which are listed down at the bottom so you know what your options are. And then if you prefer a Thursday or a Friday, again, none of these are guaranteed. We may even be going Saturdays again, but we're just trying to get a feel for what your options are. So please remember to be flexible as we're making this schedule. As of right now, it sounds like all of our clinical sites are on board for fall. Praise the Lord. So I know, very exciting, very exciting. So if you'll go in and fill that out by Sunday night at midnight, we'll give you a week to fill that out. And then we'll start looking at clinical placements when we start to get a firm confirmation from some of those spots, and hopefully be able to release some sort of clinical schedule and calendar by the end of this semester so you know what to plan for next semester. Okay? Thank you.
Oh, sure.
Goodbye, folks. Love you. Thanks for talking.
I'll give her the message. She was walking out. Let's see, 1031 clinical module. Yes. Yes, it is 1031. Okay, now we're going to talk about sterilization. This is not considered reversible. So people should be cautioned to only use this choice if they are sure that they are done with their childbearing, that they're not interested in having more children. Of course, things change, and people do end up changing their mind after sterilization, and there are surgical procedures called reanastomosis, where they try to reconnect the vas deferens in the male or the fallopian tubes in the female. But those success rates are iffy, and sometimes they definitely do increase the risk of ectopic pregnancy in the female. So there are risks with trying to reverse a sterilization. So people should think of it as permanent and not reversible. It is a minor surgical procedure for both men and especially men and Women, it's a little bit more involved, but often it's done postpartum, which is a little bit easier, easiest time to do that. So for female, it's a tubal ligation where they just sever the fallopian tube, and by whatever means that the physician chooses, they ligate or suture it off so that there's not a clear path between the ovary and the uterus. It does have a little bit of a failure rate, and actually its failure rate is higher than the implant, the hormonal implant is. So let's see, I mentioned this already. Oh, and a side benefit of a tubal ligation is that it does help protect against ovarian cancer. It requires regional anesthesia. Okay, for the male, this is the picture here is kind of the reaction to the thought of having it done. It's usually done in the doctor's office, a minor procedure, and it's an occlusion of the vas deferens. What it does is it prevents the sperm from exiting the body. So it does not affect the testosterone level at all. It does not affect sperm production at all. Sperm are still produced. They just cannot exit the body, so the body reabsorbs them. It's done under a local anesthetic, so that's kind of the reaction here to doing it under a local. Sterilization is not immediate. This is really important instruction to give so that men know that they're not immediately sterile as soon as the procedure is done. It can take as long as 2 months, somewhere usually between 1 and 2 months, to purge the sperm from the system. So they need to use a backup system or an alternative birth control in the interim. And then ideally they should go in and have a negative sperm count verified before they have unprotected sex using an alternate method. So this picture is, I don't know if anybody's into tech gurus, but this is Linus from Linus Tech Tips. And he famously, for his substantial followers, had a vasectomy. And he told everybody on his group that follows him on his YouTube channel, all about it, how it went. And then his coworkers also famously pranked him, and because he never went back in to get the negative sperm count. And so they arranged to have his wife go in on it so that she claimed that she was pregnant. She was like, you know how you were supposed to get your sperm count verified, and he hadn't. And so he gets the word that she's pregnant again, although she really wasn't. And they, of course, got it all on videotape and made a whole show out of it. And it was enough to kind of seal the deal for people to get that idea in the head that they really need to follow up with that negative sperm count. So, because the idea of getting pregnant after that is very terrifying for them. Oh, that's interesting, Victoria. Yeah, men need to know it does not, there's not going to be anything done with the testicles. There's going to be no hormonal effect, just that the sperm won't enter the body. So that, to kind of reinforce this thought, I made a little slide. What did the vasectomy say to the sperm? You shall not pass. Okay, so now we're going to do emergency contraception. This is considered, should be used only in the case of emergencies, such as unprotected sexual encounters that are totally unanticipated or unplanned, and where neither parties are using any contraception because they did not anticipate it happening at all, or a failed contraception, such as if the condom breaks. I'm going to skip down to the bottom. The nursing action is to discourage misuse of this form of birth control as just being casual birth control, where people use it. This is more of a problem for like adolescents, or where they're not being proactive to take care of birth control, and they don't want to bring up the question of, hey, somebody needs to use some sort of protection anyway. So it shouldn't be used casually, but in true emergencies. This is Plan B, and it's levonorgestrel, and it is available over the counter. It works by inhibiting ovulation and also fertilization and implantation. So it works best if it's used within 24 hours. However, it can be effective at, with diminishing. It can be used with diminishing effectiveness for up to 72 hours. Beyond 72 hours, a woman would really need to go to a provider to get a prescription strength one, and those can be used for up to 120 hours, which is 5 days. And then beyond 5 days, if an IUD is inserted within 7 days of unprotected intercourse, then that the IUD can function as an emergency contraception. So that is kind of helpful to know. Right here. It's important for women to know that it does not work if the BMI is over 29. So a while ago, about a year ago, I had a student who said one of her good friends used Plan B, and only her BMI was too high, so she ended up having the baby. It didn't work. So people need to be cautioned about that. Actually, before we get into the abortions, let's go ahead and bring up Aubrey and Mark. Are you guys ready to do your presentation? All right, come on, Mike, and if you can, come on camera as well, and I will switch to do a screen share.
Okay, I am here. Trying to get my camera to go.
I don't know if I want to turn on my camera. I'm not.
It's not required.
Decent. I look a mess.
Okay, you can just talk to us then. Thanks for coming.
Sorry, I was just grabbing food. Okay. Are you ready to go, Aubrey?
Yeah.
Right.
So we did the history of contraceptives by us.
All right, we're gonna go to next slide, please.
Sorry, it went. Okay, I was trying to pass the slide and it went to play mode. Okay, there we go.
There you go.
Okay.
Perfect. So yeah, we're gonna cover some of the ancient forms of contraceptives up until probably around like the mid 20th century, because we've covered pretty much everything else from there in class. Natasha's covered that stuff. So what we're going to be going over, we're just going to talk about some of the earliest documented forms of contraception, and then looking at documentation. It talks about how it was primarily the women's responsibility to come up with a form of contraception. It really wasn't the male. The male was just kind of there to spread his seed and do his thing, and it was up to the woman to prevent babies if she didn't want to have a baby. And so that meant that early contraceptives were usually female-controlled devices. Condoms and stuff, that stuff came later on, like the Middle Ages. And then, and through this, we'll kind of show you that men essentially used anything they could get their hands on to cover their penises and prevent pregnancies. And likewise, women were literally just, it seemed like they were just putting all kinds of things inside their vaginas to prevent getting pregnant. So next slide, please. Okay, so the first time we're going to start with, we're going to go back to the ancient civilizations of Egypt and Mesopotamia. Some of the earliest forms of contraception were these little round stones that women would place inside their vagina intrauterine to prevent semen from passing. They really relied on like the barrier method type thing. What they would do is they would take honey, acacia leaves, lint, and they would form it all together, and then they would stick it up in the vagina. And what that would do is it would just perform as a barrier. And what they also use, a thing called, I can't pronounce it right, they're called pessaries. I don't know how to say it, but what a pessary is basically anything that blocks the cervix from anything from being able to get into the cervix. And they found that if they used the acacia leaves, turned it into a gum, that it would, if they mixed that in with lint or linen, stuff like that, that it would prevent the semen from being able to get into the cervix because it would create this gummy substance. And so they also used honey, sodium, and probably the most disgusting thing is they use crocodile dung. Yeah, and so we've got like the little video on the right there. They would mix like honey, lints, crocodile poop, all that kind of stuff. Don't know why they thought the poop would work, but they did that. Another form they did was lactation. And so if they'd already had a child, they would go like up to 3 years breastfeeding the child. And they used that as an early form of birth control. And I think the most common one, this is documented in the Bible on different papyrus documents from the time, is coitus interruptus, or withdrawal, pulling out, whatever you want to call it. That was, at the time, was probably the most effective form of birth control. And next slide, please. And we also, if we go to ancient Greek and Rome, kind of the turn of BC to 80, they got more into like the herbs and stuff like that. So there was one called silphium. They used that as an oral contraceptive, and they actually used it so much that it became rare back then, and it was actually worth more than silver at the time. And even some of the civilizations out there actually put the silphium on their money because it was just so rare. In fact, now it's actually extinct. There's some kind of forms, like different types of plants that are related to silphium nowadays. There's Queen Anne's lace, which they actually still use in India. Willow, date palms, pomegranates, pennyroyal. They would crush that up and put it into like a tea. Artemisia, myrrh, rue, and parsley. And so they would actually take these plants to like abort a fetus instead of actually preventing pregnancy. And then they would also use things like cedar oil. And in places like Asia, they would encourage drinking copper and mercury to lower levels, to not poison them to death, but just keep them from being able to be fertile. And next slide, please.
Okay, so here we have the medieval and the Middle Ages. So this is where things got even more interesting. So we have the idea that religion like super influenced contraception because it was considered a sin. Because if you're gonna have sex, then it should be for reproduction. So that was stressed. That it shouldn't be for anything else. They used the same herbal methods we talked about on the last slide. They believed in using magical methods, such as like witches, which were used for abortion, because it was considered immoral and therefore witchcraft to abort a fetus. And then Asians, the upper class Asians, used little covers for the glands, the tip of the penis. They used silk and animal skins that covered that, and then drinking lead and mercury. you'll notice this picture. It has a picture of some weasel testicles tied to her thigh. That was believed to also prevent pregnancy somehow. Yeah. Who knows how, but if you had weasel testicles on your thigh, then you're good. Um, so basically, the most documented history of contraception during this time was written by men because men wrote everything. And so because of that, it only comes from a partial understanding. So we don't have the whole picture. Next slide, please.
All right. Now we're getting into like the second half of this timeline. In the 1500s to the 18th century, a lot of people continued to use traditional herbal methods, but people were starting to realize that they're not working as well as they thought they would. So you're starting to see some of the earliest forms of condoms. It's kind of up in the air whether or not like ancient Egyptians and stuff like that were using condoms. There's like hieroglyphics of them possibly using them or some kind of sheath to cover. But this is where we have like for sure documentation of them using condoms. And they would, there was a big syphilis outbreak in Europe. So they made these covers. They would make them from intestines. They would use animal bladders. They would use like cowhides, leathers. Basically, anything that they could do to make some kind of sheath or some kind of cover they would use to protect themselves against disease. The problem with that, though, is they were very inconvenient to use or to make or to acquire. And they actually didn't protect very well against disease because they had a bunch of holes in them. Or they were made improperly. And then a lot of society thought that because they had this newfound protection, that it encouraged promiscuity, and so it was frowned upon by the churches of the Middle Ages. They didn't like having that type of contraception around, and so there was this general dislike amongst the churches. And then it was just really, really hard to even get a hold of those. And even though they were used inconsistently, they became the primary form of contraception. As a lot of these plants were getting harder and harder to find, they were realizing that they weren't working. So a lot of people really relied on the condom. And they started using other materials like linen, and they would actually use like human skin, animal skins, and then they would kind of come up with their own concoctions of spermicidal chemicals. And then you would start to see these being sold in barbershops, pubs, theaters. As you would kind of see, birth control now was no longer just a female aspect. Men were kind of taking control of that, not wanting to have, they were trying to control the population, so men were kind of taking responsibility for that. So you would see them where men were hanging out. Next slide, please.
So now we're going into the 1800s and the early 1900s. And so now this was promoted heavily to lower classes, the contraception methods. So they would use diaphragms, and spermicidal douches were becoming a thing. But despite this, it was illegal for a time in this period to use contraceptive. And but it was still promoted despite that because, women were trying not to get pregnant. So more sex education came about in the mid 1800s because there was outbreak of disease during the Civil War, like syphilis. And then women would, because it was illegal to have the contraceptives, women would actually use nearly anything they could find. They sprayed Lysol up there. They put Coca-Cola up there, thinking that would prevent them from getting pregnant. Eventually, the birth control bans were lifted in a court ruling called the Sanger case, and that was in 1938. And then vasectomies were invented and they realized those could potentially be very effective. Next slide. Okay, so
I didn't unmute
now
myself.
we have.
Sorry.
No, you're good. I was
Right.
waiting for you, and I was like,
All right, so now getting into the mid to late 20th century, like she said, the Sanger case, she was actually one of the founders of the early Planned Parenthood. She's actually been in the news lately for a bunch of other stuff. They're talking about taking her name off of and kind of like disconnecting from her. But anyways, she was very influential in getting birth control out to females in the about the 20s and 30s. And so what you're going to see in the mid 20th century is your first birth control clinic actually opened in Britain around that time, and you were seeing more sex education being stressed to not only males but also to females now, telling them that, hey, you know, eventually, or that using Lysol and stuff like that isn't good. It's actually, you know, detrimental to your health. You're going to see the first cervical caps were invented. That would prevent semen from getting down to the cervix. And then in 1929, I believe it was, in Japan, a couple scientists actually figured out the process of when ovulation occurs, which was huge because now you could kind of pinpoint when everything was working. And eventually that brought out the invention of what we call, you know, the pill, as a way of manipulating female hormones to keep them from getting pregnant and kind of tricking the body into thinking it's pregnant, so you can't get pregnant. And then in the 60s and 70s, the feminist movement kind of came about, and that's when you're going to see all of these Supreme Court rulings. You got Roe versus Wade, and a couple other rulings where women were allowed legally to take control of their bodies and determine, hey, we're going to be using these types of contraceptives. So it made them more readily available. And there was another pill in the 70s that came about, the RU486 pill. Essentially, it's an abortion pill. It's something that you would take. It's kind of like the Plan B that Natasha was talking about. And so that was just another one of the big controversial things back in the time. And then so these early pills that came about in the 60s kind of led the way to what we've got nowadays. And yeah, that's it. Next slide, please. Out, please. Carter, out. So sorry.
It's okay. So for our learning activity, we're going to have Natasha put up a discussion board. So we want you to basically answer one or both of these questions. Which contraceptive discussed surprised you the most and why? And then name one thing you learned that you didn't know before. Kim, you're funny. And then I put this little meme here at the bottom because I just thought it was so funny. I just had a terrible nightmare. It was 1912, and I had to listen to a bunch of old men debate the morality of women accessing birth control. So I thought that was pretty funny. Next slide is just our works cited. Ta-da! The end.
Great. Thank you guys so much. That was fantastic. Lots of really good information. I've heard this presentation semester after semester, but you guys brought in some things I hadn't heard before, so that was fun. And the meme about the 1912, that turns out to be happening again, or kind of repeating history. It's crazy. I don't want to get into the politics of it, but yeah. All right. So now we're going to talk about elective abortion. And so this is defined as a purposeful interruption of a pregnancy. And there are various types, but they all depend on the gestational age. So when a woman comes forward asking for an abortion, the first thing we need to determine is, of course, that she's actually pregnant, but also to determine, as part of that, determine the gestational age of the fetus, because we have some limitations as to how long we can use certain birth control methods. And so the risks of elective abortion are hemorrhage, infection, injury to the uterus and cervix, infertility, and also a rare one is amniotic fluid embolism, where the amniotic fluid is absorbed into the uterine circulation and it causes circulatory collapse and DIC. So that's a very serious one. So an abortion is potentially life-threatening. So it is something that if a woman chooses to do it, it should be done by medical professionals. So Plan B is used before we even know, or the morning after pill is used before we even know whether she's gotten pregnant or not. So it's just within a few days of, ideally within 24 hours of sex. And so obviously she doesn't know whether or not she's pregnant. But for these are all things that there is an established pregnancy, and we're trying, the goal is to terminate the pregnancy. So the method that can be used if the gestation is 9 weeks or less, or within 9 weeks of pregnancy, is the method that Mark just talked about, which is RU486. It was approved in Europe long before it was approved in the United States, so it was real controversial when it was started up here in the States, but it is now an established method. So RU486 is mifepristone, and how it works is it blocks progesterone, so it breaks down the endometrial lining. And then it must be followed up 24 hours later with cytotec or misoprostol. And that causes uterine contractions and empties the uterus. So this is a two-step process. This is another time where that meme that Aubrey and Mark finished up with actually applies currently, that many states, including Utah, require providers to offer what's known as the reversal treatment. However, so the reversal treatment is if the woman changes her mind between the time when she gets the RU486 and before she gets, so after she gets the first dose of the medication that blocks the progesterone, but before she gets the cytotec that causes uterine contractions. If she changes her mind, there is the idea that she can be given progesterone to reverse the treatment. However, that treatment is not ACOG approved. So ACOG is the American College of Obstetrics and Gynecology. It has not been determined if it's effective or even if it's safe. So there haven't been enough studies done to support it. However, it is legally required to be offered as an option. The providers can inform women that this is something they are by law required to tell them is an option, but that it is not FDA approved or ACOG approved, and it is not known if it's safe or effective. Okay, so that's within 9 weeks. It's going out a little farther. If she's a few weeks farther along, she can, up through the end of the first trimester, which is up through 13 weeks. Another treatment that can be done to terminate pregnancy is a vacuum aspiration. This is the simplest of the two listed here because it does not require cervical dilation or anesthesia. And then the next option is dilation and curettage, usually referred to as DNC. And this is when the cervix is dilated so that an instrument can be inserted, the curette can be inserted into the uterus, and it can scrape out the any products in the uterus. And this one is done under anesthesia. Okay, and then if she needs a second trimester abortion, it is only offered up through 24 weeks, which is a little bit before the second trimester ends, but just this is the option is the dilation and evacuation, where prostaglandin is administered vaginally or injected into the uterus, and it induces contractions, and then the uterine contents are evacuated. In your book, the Williams, which is your med-surg book, it lists what I have crossed out here as an option, hypertonic saline injection, and that is no longer used because it has serious adverse effects. And yeah. All right, so that finishes up our contraception unit. Let's move on and talk about menstrual disorders. This is objective 7. And this is what the menstrual disorders make women resort to, at least emotionally, if not physically. Okay, so I added this little information since this came up in our discussion on toxic shock syndrome. So menstrual cups, there's only been one incident of, at least from the time that the report was given that I read about, only one incident of toxic shock syndrome, so it's rare. And potential risks are irritation, that's far more common. So it's recommended to use a water-based lubricant. And then possible infections are yeast infections and the bacterial vaginosis, which we talked about at the very beginning of this unit. Those have an increased incidence with menstrual cups, but it's still rare enough that overall they're generally considered to be very safe, as long as women use proper hygiene with them, which is listed here at the top. The cost is just a one-time cost, and they should last for years. So they're a lot more economical than tampons or pads. Let's see. Okay, yeah, so technically toxic shock syndrome is a potential risk, but it is super rare. And the one time that was developed was after as a woman, the woman who got the toxic shock syndrome, as she was inserting the cup, she caused an abrasion because it wasn't inside of her vagina because she didn't have it lubricated properly. And that abrasion is what allowed the toxic shock, the Staph aureus to take hold. Okay, dysmenorrhea is super common. It's so common it's considered normal. In fact, there is no treatment other than just, it's considered non-pathologic because it's so normal. And it's just like live with it. Non-steroidal anti-inflammatories really help with that, like ibuprofen. Then secondary, that's primary dysmenorrhea. And secondary dysmenorrhea is when there's a reproductive tract disorder such as endometriosis, or fibroids, uterine fibroids, and then they would treat the cause. So endometriosis, speaking of which, is when there's endometrial growths outside of the uterus. So ideally, all of the endometrial growths should be right here, tucked inside of the uterus. But for some reason or another, and we're not exactly sure how it happens in all situations, and it's probably has a variety of, not probably, it is determined that some of the incidence of endometriosis is caused by retrograde menorrhea, where instead of the menstrual flow all exiting through the cervix, that somehow it exits through the fallopian tube to get into the pelvic cavity. And it is also felt that it sometimes happens during embryonic development, that some of the endometrial lining gets transferred to other areas of the body. It's been found, up in the thoracic cavity. So, which is why they think probably that was an implant from embryonic stage of development. So these endometrial implants cause a great deal of discomfort at the time of menstruation, because when the woman menstruates, she bleeds not only through the cervical opening, but also all of these implants that are outside of the uterus also bleed into whichever cavity they are in, and that causes a lot of pain and discomfort. Endometriosis can cause infertility, and in part due to it can cause adhesions along the fallopian tube so that they're not patent. Signs and symptoms are pelvic pain during menstruation, and it's diagnosed by laparoscopy, which oftentimes, as they do the diagnosis, they're prepared to observe for adhesions and to go ahead and do a lysis of adhesions to remove the adhesions at the same time. So those are the treatments that I just talked about, the NSAIDs, the laparoscope, and also the oral contraception. That's one of the non-contraceptive benefits of the pill. The hormonal oral contraceptive option is it does help to suppress ovulation, thus it helps to suppress endometrial implants. Okay, the next topic is PMS, premenstrual syndrome, and PMDD, which is premenstrual dysphoric disorder. And these are associated with the second half of the menstrual cycle, which is the luteal phase. So just remember that. The luteal phase goes up until the time of menses. So the luteal phase ends when the woman starts her next period. So it happens, PMS and PMDD happen generally 1 to 2 weeks before menstruation. Okay, so the cause is unknown, and there's been a lot of studies and a lot of ideas about what causes it. It seems really obvious that it is caused by some menstruation, but not all women have it, although it is one of the more common female disorders. And let me see if I got. Oh, I think it's like 15% of women are better, more. I don't know why I'm blind to the. I was looking for the effectiveness. That reminds me, I was looking for the effectiveness of lactation amenorrhea, and I did look that up, and it's 98% effective. So that one is pretty effective. That's going back to last week's discussion. But anyway, premenstrual syndrome is super common, but it doesn't happen with everyone. So for some reason, women seem to be more sensitive to the cyclic fluctuations of the hormonal levels, and serotonin. Serotonin is what affects the mood, because it does have a negative effect on the mood, and there does appear to be a genetic component in many cases. So signs and symptoms are, there's two types, physical and emotional. And to be diagnosed, a woman needs to have at least one physical and at least one behavioral or emotional symptom. So the physical are breast tenderness, abdominal cramping and bloating, headache, edema, weight gain, acne, and then emotional or behavioral are irritable mood, angry outbursts, depression, social withdrawal, anxiety, panic attacks, and trouble concentrating and confusion. So, and that's the first part of the diagnosis is that they need to have at least one of each of these types of symptoms. And the second part is that these symptoms improve once menses start. So if these are just continuous symptoms, it could be this is going on, that it's just the personality. Anyway, that's treatment for both PMS. Oh, wait a second. Where do I have? Am I missing a slide? I need to have PMDD up there too. Let me take a look at that. Is it on that slide? Okay, sorry, I must have. Oh, here it is at the top. So PMDD is the more severe form of PMS. I took down the hideous picture of a woman with PMDD, and I didn't recognize this slide as PMDD without her picture on it. Anyway, so the signs and symptoms are the same as for PMS, only there needs to be more of the symptoms. So there has, instead of one of each, there needs to be 5 symptoms, and they have to be severe enough that it gets in the way of the woman's relationships. It interferes with relationships, her ability to work or function, and her career or her academics. So the cure for PMS and PMDD is sadly not until they reach menopause. So because as long as they're menstruating, they're going to be susceptible to this disease process, but there are some effective therapies that can help alleviate the symptoms. So one of which is nutrition. If the woman has PMS, nutrition does seem to be helpful, like calcium supplements or magnesium, vitamin D. However, this does not seem to help. It's not effective for the more severe form of the disorder, the PMDD. Other treatments are diuretics to help decrease without water gain, the bloating, and hormonal contraceptives. This is another non-contraceptive benefit of the pill. And then SSRIs, antidepressants, which interestingly enough, that they can be effective even if just taken during the luteal phase or the second half of the menstrual cycle. So, or they may just take them daily, like a person who's taking them for depression. Nursing care is to teach to incorporate lifestyle changes all month, not just when symptomatic. So having a healthy lifestyle, getting good exercise, getting a good amount of rest, doing all the things that our mothers tell us to do. Exercise, eat right, sleep right, relieve stress, and then also don't smoke or vape, because those seem to contribute to the problem. And then a diet is actually helpful I think I misspoke earlier when I said nutrition only helps with the PMS, not PMDD, but I was referring specifically to the calcium supplements and these supplements. However, a diet is somewhat helpful. It's not going to relieve all of the problems. It should be used in combination. If the woman has PMDD, she'll probably need to have these other medications as well as the diet, but it's good to use in combination. So the diet is recommended to limit refined sugars, alcohol, caffeine, and eat foods that are rich in complex carbohydrates like vegetables and whole grains, nuts, and fruit. And then I added this, I don't think this is on your slide, in your PowerPoint, but it turns out that cruciferous vegetables, which are the Brussels sprouts, broccoli, cauliflower, and cabbage, these help to metabolize estrogen more effectively, so minimize PMS symptoms. So all of those are effective. Okay, moving on to objective 8. This is menopause. So we're going to talk about both perimenopause and menopause, and you do need to know the difference. And it's really simple. The difference between perimenopause and menopause is the question as to whether or not the woman is menstruating. So if she is done menstruating, if she's not having periods anymore, then she's in menopause. However, if she is still having her cycle, even if it's super irregular, that's perimenopause. So by definition, menopause is the permanent cessation of menses, and it is diagnosed retroactively. So we don't diagnose it until it's been 1 year since her last menstrual cycle. So let's say the woman is starting her last menstrual cycle on, let's just say today, July 27th, 2020. And she doesn't have another menstrual cycle for the rest of her life. However, we cannot diagnose her as being menopausal until a year from now, on July 27th, 2021. And then we look back at that point and see that she has no has had no further menstruation. Then we can say she was menopausal as of today's date. So just diagnosed retrospectively. It's caused, the signs and symptoms associated with menopause are caused by the decreased hormone production, which is a natural consequence of aging. So perimenopause is the gradual decline of the hormones. So she'll be having all of these symptoms that are listed here. She may be having these symptoms. So not all women experience all of these symptoms, but these are all the possible symptoms that we might see with the perimenopausal and a menopausal woman. So just to reiterate, irregular menses, this symptom applies only to perimenopause, because if she's no longer menstruating, then she's menopausal. So, but all of the rest of these refer to both menopause and perimenopause. So the pH shifts, it becomes more alkaline, which makes her more susceptible to infections, especially yeast overgrowth. It really has a huge effect on the mood. So a woman who is perimenopausal and menopausal may experience more anxiety, irritability, skipping down, depression. Although women who are menopausal, they experience depression more as a anger than a feeling of sadness. There's a decreased libido and dyspareunia, which is painful intercourse, vaginitis or urethritis, inflammation of the vagina and urethra, hot flashes. These are considered vasomotor instability, which it's not known why this happens, but it is attributed to the changes with the gonadotropin hormones. Women who have hot flashes are also more likely to suffer from depression and insomnia. So difficulty sleeping, insomnia, really common with perimenopause and menopause. So the loss of estrogen puts a woman at increased risk for heart disease, osteoporosis, loss of the toning effect of the muscles, so decreased pelvic muscle support, and then the mental changes, which I talked about, the depression and insomnia, anxiety, and memory problems. So nursing care is to teach the risks and benefits of hormone replacement therapy, which we'll go over on the next slide. And it's best to counsel women to begin hormone replacement therapy. If she's going to use it, she needs to use it, start it early on during perimenopause. And that is to maximize the benefit of the treatment and also to reduce the risk for complications, which we'll go over in a minute. And also women should be counseled to use hormone replacement therapy for as short a duration as possible, again, to decrease the risk of complications. And teach women to eat a healthy diet, similar to the one that we recommend for PMS, and which includes limiting refined sugar, caffeine, and alcohol. And also this is kind of a transition time in life that can be hard for some women, so it's good to counsel them to look forward, look ahead to new opportunities instead of regrets about losing the past. So these are the things to consider in deciding whether or not to use hormone replacement therapy, or sometimes it's called estrogen replacement therapy. There are various means of using hormone replacement therapy. One is oral medications, another is transdermal, and then a third is a vaginal route, like a vaginal ring. Most of the benefits come from using an oral or a transdermal route. So as you can see here, the benefits are listed here. So the vaginal route, it just helps with vaginal symptoms like vaginal dryness or irritation, things like that. Let's talk about the benefits first. These again are just from the oral and transdermal route, is to be relief from hot flashes. Hormone replacement therapy is 100% effective in relieving hot flashes. So much so that if a woman continues to have hot flashes after she's put on hormone replacement therapy, the providers have to look for another cause of what's causing the hot flashes, because the expectation is that any hot flashes caused by menopause will be relieved by hormone replacement therapy. And it also helps to improve the depression associated with menopause, and it reduces the risk for hip fractures, and it also decreases the risk for colorectal cancer. So those are all excellent benefits. However, the risks are pretty significant. These were found in a study, the Women's Health Initiative, that was done about 15, 20 years ago. It was supposed to be a longitudinal study, but they stopped it early because there were women who, significant numbers of women who were developing cardiovascular disease. Now let's go back a slide. This was confusing because notice that the loss of estrogen causes heart disease. So it was assumed that giving women estrogen would diminish or decrease this risk. So it was super surprising when women who were treated with hormone replacement therapy were actually having a higher rate of stroke and heart disease than women who weren't on hormone replacement therapy. So they did stop the study early for this reason, and also because there was significant higher risk for breast and uterine cancer, which that makes more sense because those are, remember when we talked about the risk of cancer is often affected by prolonged or additional exposure to estrogen. So that those make perfect sense. But the longer a woman's on hormone replacement therapy, the greater the risk for breast and uterine cancer. But this cardiovascular risk was confusing, and what they realized is when they did the study, they threw just in women, menopausal women of any age in the study. So the woman could have been anywhere from her mid 40s to her 70s. And if a woman who's been menopausal for 20 years all of a sudden starts getting hormone replacement therapy, those are the women that have the cardiovascular disease. It wasn't the women who were like barely perimenopausal or early menopausal. Those women weren't having problems with cardiovascular disease. That is why doctors are still prescribing hormone replacement therapy. They are doing it very carefully, providing it to, like the slide said, starting it in women who are perimenopausal or very early menopausal, because those women are not going to be at increased risk for cardiovascular disease when treated with hormone replacement therapy. So this is kind of a little bit of a confusing information. I'm hoping I made that as clear as possible. Does anybody have any questions about hormone replacement therapy and its risks and benefits? I'm going to tell you right now, you need to know these. You're going to need to know this information for the test. So let me ask again, any questions about that? Looks like I don't see anybody typing in the chat box, so I guess we're good to move on. One last thing we'll cover regarding menopause is that once women get to be perimenopausal, where their cycles are super sporadic and irregular and spaced out, a lot of times women think, oh, I'm not fertile anymore, and so they'll stop using contraception, and then this happens. You have a positive pregnancy test right when you thought that you weren't never going to be fertile again. So women need to be informed to continue to take contraception unless any of these apply. So always use contraception unless a woman is actively trying to become pregnant. Menstruation has stopped for over a year, which, remember, that's the definition of menopause. It's been over 1 year since the last menstruation. Or if she's had a surgically induced sterility, like a hysterectomy, a bilateral oophorectomy, or tubal ligation, which this question sometimes comes up is menopause can also, in addition to beginning when the ovaries stop ovulating, or once the hormone levels drop and the woman stops menstruating, menopause can also be surgically induced if the ovaries are removed. Okay, so we've been talking about women so much. It's time to switch and talk about the guys. So I've got a little song for that. Okay, so I actually was challenged about a year ago. One of my clinical group challenged me to find a way to fit that video in. So I thought that works. So I thought it worked well enough that I just kept it. Oh yeah, so here we are talking about women. This slide was supposed to come before that. I don't know how I got it out of order. Now we get to talk about the guys. So this is our final objective. What? Mark, do you have a story to tell us? While he's typing that. So this is our final objective is male reproductive disorders, starting with structural disorders. Do you need to come on mic and tell us about this, Mark?
Yeah, I'll just do that. It's easier. So when I was in Iraq in 2007, Toby Keith was doing the USO tours. And he just happened to come on to like our tiny little base, and I was stationed with the special forces guys who had all the big guns. And he wanted to shoot the 50 cal, so he came up and on our building, and we all went up there and we're shooting the 50 cal with him.
Oh, what a great! That is so cool. I'm glad I shared that video to hear that.
Yeah, he's a cool dude. Like he would go to like the places that nobody wanted to go to. Like he wouldn't go to all the big frilly bases. He would go to the ones that were all dirty and disgusting, and so.
Awesome. Well, that video I started for you is worth watching the whole thing. I think I just showed the first minute of it, but it's fun to watch. Yeah, thanks for telling us about that. So, okay, so the first structural disorder we're going to mention is hydrocele. This is more common in newborns. And this picture shows just normal and then non-communicating versus communicating hydrocele. That is a detail you do not need to concern yourselves with. So it's common in newborn, and it usually resolves spontaneously within a year. I mean, that's where we're most likely to see hydrocele is in newborn. And no treatment is necessary unless it causes discomfort or is so large that it threatens the blood supply. In that case, it can be surgically repaired. It can also have a needle aspiration to drain the fluid. Okay, next is varicocele. This is the one that's associated with infertility because it increases the temperature of the scrotum and the testicles, which diminishes sperm production. So varicocele is a varicose vein of the scrotum. And signs and symptoms, I already talked about hyperthermia association with infertility. And signs and symptoms are dull ache, scrotal pain or discomfort, bluish discoloration, and its treatment isn't needed unless it is significantly uncomfortable or if the man is trying to have children, and for fertility purposes, it can be surgically repaired. Torsion. This is super painful, excruciating painful, 20 on a scale of 0 to 10 sort of pain. And it's more likely to happen in adolescence and oftentimes adolescents are uncomfortable going to their mom and saying, hey, I've got pain in my scrotum. So they'll be kind of vague about saying what their symptoms are. Not always, but often. So healthcare workers need to be suspicious that this might be happening if a man appears to be, especially a young man, appears to be in excruciating pain. And what it is it's a twisting of the testicle, like you see here. It can twist like 180, 360, even 720 degrees. And it can cause infertility if it's not treated promptly. So it requires immediate surgery for 2 reasons: to relieve the intense pain and also to preserve fertility. The reason why it causes infertility is because it traumatizes the blood testes barrier. So we've got a blood-brain barrier. There's also a blood testicular barrier. And if that is damaged, then that man's immune system can attack his own sperm production, and not just the affected testicle, but in both testicles. Let's see. The symptoms are intense scrotal pain, as you might imagine, also radiating into abdominal pain, scrotal edema, nausea and vomiting, and possible fever. It's associated with like athletic activity, things like that. Okay, prostate disorders. There's a few here. We'll talk about prostatitis, benign prostatic hyperplasia, and prostate cancer. So first is prostatitis. This is just an FYI. It's an inflammation of the prostate gland, and it causes pain and swelling. It's usually caused by infection, STIs, UTIs, urethral trauma, and it's treated with antibiotics. And we're going to go into a little bit more detail in the benign prostatic hyperplasia. The prostate just keeps growing throughout the lifetime of the man. So the older he gets, the larger the prostate is. And so it's extremely common. In fact, more often than not, men have it. It occurs in 75% of men over the age of 70. And it's just a natural consequence of aging. So signs and symptoms are it requires more effort to empty the bladder. It takes longer to empty the bladder because there's a slower urinary flow, a smaller stream. There's increased urgency and frequency. There's difficulty starting a stream, and once they get it started, it's harder to stop, meaning there's dribbling, a problem with that, diminished force of stream, and then a feeling that the bladder hasn't fully emptied. So all of these are pretty uncomfortable symptoms to live with. The treatment is, however, watchful waiting. As long as all it is just kind of a slower stream than what the man is used to, then that's not too life-altering, so they wouldn't usually do treatment just for that. So they would just watch and see if it gets to the point where it's causing more significant discomfort and problems. And then they can, treatments include medications, using male hormone blockers to help to shrink the prostate. And then another is a smooth muscle relaxant for the prostate and bladder neck called Flomax, which helps with urinary flow. And then it can also be treated surgically. There's 2 types of therapies. The TURP, transurethral resection of the prostate, is when they do as pictured here. They insert an instrument through the penis up to the prostate, and it's got a little blade on it that it chips away at the prostate, and or I guess not a blade, but a wire loop. And then the other one is aquablation, which, let's see if I can get, I've got a video of it, and I thought I had the link here, but it's Okay, now I've got the link for you. So it just has uses aqua therapy. So water comes out of the jet to reduce the size of the prostate. This is a newer therapy. It's still under, it is being used, but its effectiveness, it has very similar results as far as effectiveness goes. The expectation is that it will eventually become more effective and have decreased risk, decreased complications for bleeding, urinary tract infection, and erectile dysfunction once it's used more. So following both of these procedures, a system like this is set up where we've got the Foley catheter that has a three-way port, which allows this hookup. This is normal saline, 2 huge bags. I think there are 2-liter bags each of normal saline, or I can't remember. It's an irrigation fluid, and it flows into the catheter, and it goes into the bladder, and then flows back out through the bladder, and rinsing out the tips and things that the tissue that was removed under the procedure, whether it was the TURP or the aquablation. And that's just done for overnight. So the procedure would be done on one day, and then for about overnight into through the next morning, it would be discontinued, and the man be discharged, or the treatment can be stopped. Moving on to prostate cancer. This is the most common cancer in American men. Most prostate cancers grow very slowly, so it's got a great, one of the highest 5-year survival rates of any cancers. Here are the risk factors. Age over 55, so the older a man gets, the higher the risk for cancer. Just like for the women, the older women get, the higher the risk for reproductive cancer. African American men are also at significantly higher risk for prostate cancer, and again, that is felt to be in part due to decreased access to care. But since it is a higher risk for African American men, we're going to recommend screening them a little more routinely, and we'll talk about screening on the next slide. And also, it is associated with the BRCA gene. So if there's a family history of cancers or BRCA genes, then these men also have a higher risk of prostate cancer. Things that decrease the risk for prostate cancer are a healthy diet, exercise, and maintaining optimal weight. Signs and symptoms. There are essentially no signs and symptoms in the early stage, but once it has progressed or advanced, then there may be hematuria or blood in the urine, bladder infection, urinary retention, difficulty urinating, which reminds you a little bit of benign prostatic hyperplasia. If the cancer has metastasized to the hip, there will be back and hip pain, and then weakness and weight loss. So let's talk about screening. Men aged 55 through 69 may be screened. We don't screen younger than that because they're not likely to have prostate cancer is not likely to be an issue any younger than that. And we also do not screen over 69. So men age 70 and over are not screened because it is such a slow growing cancer that if it were to develop, it is not likely that it would be the cause of death for the anyone who is diagnosed after 70. But between the ages of 55 and 69, there's what we call the combined, all of a sudden the word just left me, where you discuss the options with the man. So both the doctor and the man will combine to decision making. So the provider will give the statistics and information to help the man to make the decision on whether he or not he wants to be screened. And I've got the statistics on the next slide for you, but there is a really high incidence of over-diagnosis with prostate cancer. So that's why they're not screening routinely like they used to. So they used to just routinely do the prostate-specific antigen, the PSA blood test, and it turns out it has a really high overdiagnosis level. So they try to limit the number of men they screen in the first place so that there's not such a super high incidence of over-screening. But African-American men would be someone who you would want to screen because they are at increased risk of a significantly increased risk of prostate cancer. So if this PSA is a screening test along with doing a rectal exam to detect if there's any enlargement of the prostate. And then if both of these are positive, then a follow-up test would be a prostate biopsy to see if the biopsy has a cancerous growth. And then treatments for prostate cancer are, well, first, before I say what the treatments are, I should say that the side effects are very undesirable, which is a major reason why we don't want overdiagnosis, because as soon as there's a diagnosis, then there has to be a treatment, and the treatments have these serious side effects, which are erectile dysfunction, hot flashes, breast tenderness, osteoporosis, urinary incontinence. So most of those are things that men don't really want to live with if it can be avoided. So the treatments are testosterone suppressing medication, which can be done in the early stages of prostate cancer, and then more advanced cancer they can do a radical prostatectomy to remove the prostate and any affected lymph nodes. And then there is this medication that was recently approved by the FDA. It's Provenge, I'm not sure how they pronounce it, but it's an immunotherapy. It works kind of like a vaccine to boost the body's own immune system. Okay, so this is showing you the statistics and why they're trying not to overscreen. So of every 1,000 men who were being screened for prostate cancer, a full quarter of them were coming back with positive results. Whereas only 20 to 50% of that number actually had cancer. And then the overdiagnosis, we're finding all of these cancers and treating them. So of all of the people who decide to be treated, only three avoided cancer, only one life was saved, and 5 died from the cancer anyway. So these are not super stellar results for having screened out so many people, or having had positive results. So for every 240 positive screenings, it benefited about 4 people. So because the though that benefit is relatively small. For those 4 people, it makes a huge difference. But so I don't mean small in that regard. It's the number needed to treat for every. Yeah, I think you guys understand what I'm trying to say there. It just reinforces why we're really careful about screening. So instead of randomly screening people by the thousands, we're trying to be more selective and only screen the people that we really feel are going to benefit from having the screening done. Yeah, good point, Mark. That's exactly right. Okay, so this is the number of cancers, the male cancers. You can see that by far prostate cancer is more common than any of these others. Men do have breast cancer, but it's only about 1% of what the women have. And it's even less than penile cancer, about the same as penile cancer. Testicular cancer is more common. It is the most common cancer in younger aged men. So men between age 15 and 34 are going to have more likely have, if they develop one of these cancers, it's going to be penile cancer. But you can see that the numbers are still, not testicular cancer, but you can see that the number of testicular cancer is just a fraction of prostate cancer. I had this one in just to kind of show the difference. So breast cancer in women is still far more common than prostate cancer in men. Okay. This is just an FYI. You're not going to be tested over this. Just like the American Cancer Society stopped telling women to do breast self-exam, they also have stopped telling men to do self-testicular exams. However, for both men and women, they still want both men and women to be familiar with what's normal for their body. So just that's why I kind of explained breast self-exam, and for the women and men, they should just be aware of what's normal. And treatment for testicular cancer is to remove the testicles. And if they are diagnosed and need to have their testicles and spermatic cord and lymph nodes removed, the man can save his sperm and bank it if he wants to try to have children later on in life. Okay, this is the last thing we're going to talk about with this unit, and that is low testosterone. So the FDA allowed people to start advertising medications, and as soon as the makers of testosterone treatment started putting things like this up as advertisements, men were like, hey, I want some. And so then they started overdiagnosing or overprescribing testosterone therapy. And we realized that it doesn't always cause this healthy heart. It does seem to increase the risk of cardiovascular disease in men. Just like hormone replacement therapy increases the risk of cardiovascular disease in older women, it also can increase the risk in men. The jury's still not out. They're still studying that, but there is a definite potential for that problem. So they're trying to be more cautious and only prescribing testosterone therapy in men who really need it. So the symptoms of low testosterone are just kind of pictured here. Low sex drive, erectile dysfunction, body hair loss, fatigue, loss of muscle mass, increased body fat, especially around the abdomen as pictured here, decreased bone mass, and mood changes like depression, memory problems, difficulty concentrating, the same sorts of things that you see women, menopausal women at risk for. And it's caused by a variety of things, either testicular injury or cancer, hormonal disorder, infection, type 2 diabetes, obesity, and long-acting opioid use, as well as like genetic disorders like Klinefelter syndrome, which, if you remember, Klinefelter syndrome is when there's two X chromosomes with a Y chromosome. And then, so aging also plays in, because the older a man is, the lower the testosterone level is. And the goal of testosterone replacement therapy is not to bring their levels up to what a younger man's would be, is to bring it up to what it is normally for a person of that age. So let's say this is, this one right here is age 60. And if a 60-year-old man has a low testosterone, that means that it would be lower than what you would find it normally. So the treatment goal would to just be to bring it up to what's normal for that man's age group. Testosterone levels need to be checked the first thing in the morning, because it has kind of a diurnal rate. So the level dips in the evening and it's high in the morning. So we don't want to be checking it after the man is worked a full work day and he's checking in the lab on his way home from work, because it's going to obviously be low then, because that's when it's naturally low. So you have to check it first thing in the morning. And then if it's low, it has to be checked again just to confirm that it's low. And once it's found to be low on 2 separate occasions, then he's likely to be prescribed testosterone therapy. Men who are on testosterone therapy need to have their hematocrit level checked, because testosterone is similar to erythropoietin. That's just a little FYI detail. You don't need to memorize that. But so testosterone supplements can be given in injections, and the amount and the frequency varies depending on the man's preference. It can also be given as a transdermal gel or patch. And if it's applied as a gel, he needs to be instructed to place it somewhere where other family members aren't going to be touching it. So you wouldn't necessarily want to put it on the arm where somebody else might touch and be exposed to the testosterone, because it will transfer to whoever touches it. And which the man doesn't want his wife and kids to be higher in testosterone. They're just coming out with sub-Q implants, just that are longer acting. And then oral route can be used in men who have a medical condition such as Klinefelter syndrome, because the liver clears enough of it that men who have low T, because they're older, it's not effective to take it orally. Okay, that's another FYI. You're not going to be tested on that little detail. But you do need to know the risks of therapy, which are sleep apnea. It stimulates prostate growth, both benign and cancerous. So a man who's at increased risk of prostate cancer, you're not going to want to put on testosterone therapy. It decreases spermatogenesis. So if a man is trying to conceive or have children, they should not be given testosterone therapy. And I explained why that is, why it decreases spermatogenesis when we talked about fertility treatments. Cardiovascular, it does definitely increase the risk for deep vein thrombosis, which is a concern. And there are several studies that have found a possibility that it also increases the risk for heart disease and stroke and death. Again, they're doing more studies to confirm that is an actual true risk. And it also can cause gynecomastia, that's enlarged breasts, and then acne and male pattern baldness. I believe Oh, yeah, this is just the last slide. All right, so we're finishing up right now with Unit 18. How long of a break do you guys want for lunch? Do you want just like a half an hour? Or should we do a full 40 minutes? 40, okay. Let's do a full 40 minutes. So that puts us, we'll say we're in class at 11:40. So we'll start up again at 12:20. Okay, and then when you guys finish up with Carolyn, I will get back on and do a review with you. I'll send out an invitation for a review. All right, we'll let you go. Have a nice lunch. Bye.